Welcome everyone to the next in our webinar series, Getting to the Heart of Fertility. Tonight, myself, Samir Jacker, and Dr. Nicole Hope will be talking upon a subject that we deal with very frequently in our day-to-day practice of recurrent implantation failure during IVF treatment. So we hear a lot about recurrent implantation failure, and today what we want to discuss is what it really is. How can we define it? What factors can actually influence success during IVF? And what sort of interventions can we take to improve success rates? And the little cartoon on the right is really to demonstrate that an integral part of the process is a blastocyst embryo attaching to the endometrium. In the old days, we thought that this was a passive process of an invasive embryo simply attaching to the wall. But we now know that this is a very active process of the endometrium actually interrogating the quality of that embryo and making a decision about letting that embryo in or not. So unfortunately, when talking about recurrent implantation failure, there is no single definition that is universally agreed upon. In the old days, well, in the early 2000s, there was talk about defining it as 10 embryos being transferred without success. But back then, a lot of those embryos were earlier in their development at the time of transfer, either cleavage stage or day 3 embryos, whereas nowadays we are using mainly blastocyst embryos that have better success rates. So could we therefore define it by the number of IVF cycles? Could we, as previously, define it by a fixed number of embryos being transferred and not achieving a pregnancy? The problem with that is it doesn't really take into account things like embryo quality, what stage the embryo is at transfer. And of course, nowadays with the pre-implantation genetic testing that we're able to do, what about taking into account the chromosomes and chromosome testing? And we know that the most profound single influence on IVF success is the age of the female partner or egg donor. So the generally accepted definition of recurrent implantation failure, and this is a bit wordy, it is the failure to achieve a clinical pregnancy, i.e. a pregnancy with a heartbeat, after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles. And this definition does include that it does pertain to a woman under the age of 40 years old. And the reason that that definition restricts to that is that it does reflect the profound impact of chromosomes or abnormal chromosomes in the embryo above the age of 40. But of course, we do have patients who suffer from this problem, and the same sorts of things that we look at for those under the age of 40, we do look at for those in that category. And we see that this affects about 10% of our patients clinically, which is a significant number. So coming on to what we need for a successful IVF pregnancy, the analogy I like to use is the seed and the soil. The embryo, our seed, has to be of good quality, and the soil or the environment that it's placed into also needs to be receptive and conducive to that embryo implanting and proceeding. For instance, even the best seed put in an infertile soil won't sprout, and similarly, even the most fertile soil can't support an implantation if the seed itself or the embryo is not of a high quality. And of course, the quality of the egg and sperm have a profound impact on the quality of our embryo. So just coming back to age and infertility, and this is with respect to natural fertility, we see a very large reduction in natural fertility between the 20s, 30s and into the early 40s. At the same time, we see a very large increase in miscarriage rate. And again, all of this is driven by chromosomes. So the chance of an embryo having chromosome errors does start to take off quite significantly above the age of 35, which is exactly where we see the big reduction in overall success rates, but also in the increased miscarriage rates. That fall in fertility is exactly mirrored in IVF, albeit with that more steep slope at the end of the 30s and into the 40s. And the fall in fertility is driven by the abnormal chromosomes in the embryos, with increasing frequency, with increasing age. And the blue line is sort of to demonstrate that once you do find within a batch of embryos a normal one, we do get very good pregnancy rates. It's just the proportion that we find in the older age groups or above the age of 40 diminishes quite rapidly. So, looking at those factors that influence embryo quality. So clearly, the quality of your eggs and sperm are going to have a major impact on the embryo. How do we actually determine, well, what are the quality of the gametes? Well, on the male side, it's a little bit easier. We can perform a standard semen analysis, which looks at things like how many sperm are there, what's the shape, how motile are there. And then there are some more detailed tests like DNA fragmentation. And high DNA fragmentation is something that is associated with much poorer embryo quality and IVF outcomes. The problem is, though, egg quality is much more difficult to measure. To get a view of an egg, normally it has to be already in the lab, so hence really only through the IVF process. People do ask me, does AMH and raised FSH levels predict quality? Not reliably is my answer. I think they do more reliably give us an indication of quantity of eggs rather than quality. The quality of eggs is, though, highly predicted by female age. Okay, and there are certain conditions that are also associated with reduction in egg quality, particularly polycystic ovaries or polycystic ovarian syndrome, and we sometimes use differing protocols for people in that situation to make up for that fact, and endometriosis. Endometriosis can have a profound impact on egg quality and quantity, even in patients at a young age. So what are the interventions that we can do to influence the quality of egg and sperm? Well, obviously we can't reverse aging, but there are some lifestyle factors that really we can look at to improve the quality of both egg and sperm. So cigarette smoking is probably the number one damaging factor that we can address, both for men and women. Now, even a reduction in cigarette smoking is better than none at all, but if you can stop altogether, we do see a fairly quick improvement in certainly DNA fragmentation on the male side. Again, the measure in the female is a little bit harder. We know that dietary antioxidants, so all those different coloured vegetables, your lycopenes in tomatoes, dietary antioxidants are beneficial overall for health, and looking at moderating the caffeine and alcohol intake. Now, some patients say to me, well, should we abstain altogether? Probably a glass or two, a cup or two of coffee a day is of no real issue, but it's really the extremes, 3, 4, 5 cups of coffee you probably avoid. And similarly, alcohol in small amounts is fine, but in particular, looking at the weekend binge sort of pattern of drinking, that can certainly have a profound impact on gametes. And then there's, should we routinely supplement antioxidants? And certainly a general pre-pregnancy multivitamin is really important. You could add in specific things like coenzyme Q10 and vitamin E. And the reasoning behind that is that they are powerful antioxidants. The damage that's done to DNA in sperm is oxidative damage or oxidative stress. And similarly, aging in eggs is oxidative stress. The next thing is really looking at our own health in terms of weight. And this year hasn't been great for it. We do try to get the male and female weight to as close the normal range as possible, so normalising the body mass index. I think it's important, even if you don't manage to shed kilos, there is still a benefit from exercise in general. That aerobic exercise does help cellular function. Okay. Avoiding drugs and medications, harmful medications where possible. Now, of course, there are certain medications people need to be on for various medical conditions that we can't avoid. We try to change them to those that are going to have the least impact on eggs and sperm. And specifically in the male, if they're diagnosed with a condition called varicocele, that's a dilation of the veins around the testicle, we know that's associated with an increased heat around the testicle and worsening of DNA fragmentation in the sperm, and there is reasonable evidence for those with abnormal sperm parameters that varicoceles should be treated. What can we do on the lab side of things? Well, it comes to those sorts of interventions that you discuss quite routinely with your fertility specialists. There's some evidence that ICSI may be superior to IVF for those with very abnormal sperm parameters, in particular those with the increased DNA fragmentation. We do have the option of the high magnification ICSI, which I'll discuss in the next slide, that can really help to select out the best sperm in the ejaculate. For the egg and for the embryo together, well, we can look at the kind of stimulation protocols we're using. Do we change to the older style down-regulated cycles that can benefit those with endometriosis, for instance? Do we add in some LH activity? We routinely grow to blastocyst now, so I think that's not controversial in any way, but really emphasising that growing out to the more advanced stage is associated with better quality embryos and higher pregnancy rates. We at New Life use all undisturbed culture and a system called the Embryoscope. What does that mean? Well, traditionally IVF you had to move embryos in and out of incubators in order to assess them, to see what they're doing on the fertilisation stage and at day 3 and day 5. We have essentially the most advanced sort of culture system that incorporates a camera within the incubator itself, and that means instead of exposing your embryos to large temperature fluctuations in carbon dioxide concentrations and pH, they stay absolutely stable across the 5 to 6 days of culture. So we feel that gives us the best possible chance of every egg that's able of getting to blastocyst. Coming back to IMSI, what is that? Well, there are certain things that you can see in ICSI at super high magnification that you can't see at the standard sort of magnifications. And you can see from the little picture that a sperm that might be fine for selection through standard ICSI, when you actually do the 6,000 times magnification, you can see these little holes or vacuoles in the sperm, which are an indication of suboptimal quality, and we would deprioritise those sperm for use. So who benefit from that technique? Well, certainly those with the severely abnormal sperm samples, those with the high DNA fragmentation, as I mentioned earlier, the poor blastulation, and of course what we're talking about today, the recurrent IVF failure. Coming back to what I alluded to earlier, that older eggs have more chromosome errors, and that leads to the lower implantation and higher rates of miscarriage. And that again comes back to what I mentioned earlier about it being an active process of the endometrium detecting, is this a good embryo that's going to result in a healthy pregnancy or not? And in fact, the job of the healthy uterus is to reject those embryos that are abnormal. So testing of chromosomes through pre-implantation genetic testing for aneuploidy, that's a big long way of saying testing the chromosomes in the embryos, does increase the pregnancy rate per transfer and dramatically reduces the miscarriage rate. The only caveat behind that is for some of our patients who are struggling to get to blastocyst, it's hard because we actually do need them at that advanced stage to be able to do the genetic testing and contain enough cells in order to perform the testing safely. The other problem is there'll be a high proportion of cycles, particularly those in the older age groups that have no embryos detected that are normal. And that's exactly reflected in this graph here. Older women produce less normal embryos. That said, once you do find those normal embryos in older women, they actually do have high implantation success rate. And coming back to the fact that the uterus can actually detect normal versus abnormal, good embryo versus not. And PGT can be done at any age, but it is of most benefit to those above the age of 35. The graph also shows the proportion of embryos that are abnormal. Okay, so from the age of 38 to 40, 62% of embryos are abnormal, so more than half. And that rises up to 84% above the age of 42, which is significant. The vast majority of embryos at that stage are abnormal. And then the proportion of cycles that lead to at least one normal embryo also falls. It's in the high 80s or 90s up until 35 to 37. And again, the dramatic fall through to only 33% of cycles at 42 having a normal embryo. And just coming back to what is PGT, we create those blastocysts in the lab, whether that's day 5 or day 6 of the embryo culture. We take 5 or 6 cells from the trophectoderm, which is the outer part of the embryo or placenta, the part that forms the placenta. And we can safely take those cells without affecting the pregnancy. We send those off for testing and the results take 2 to 3 weeks. So that's a major intervention that we do routinely for people whose previous IVF has not been successful. Now, I'm going to hand over to my colleague, Dr. Nicole Hope, who's going to talk about the more general factors that impact implantation.
Hi everyone. Hopefully I haven't dragged you away from the Olympics. So Samir's done a great job talking about the seed, about the eggs and the sperm and the embryos. And I'm going to talk to you now about the soil. So the environment in which the embryo is implanting and how that environment can affect implantation. So firstly, I'm going to talk to you about some medical conditions. On the left-hand side of the screen, I've written autoimmune conditions and endocrine conditions. Autoimmune conditions means these are diseases where your own body makes antibodies that can effectively attack other cells in your body. And there are some well-known autoimmune diseases that you might have heard of, in particular type 1 diabetes, also lupus, but there are also other autoimmune diseases that can affect the thyroid gland as well. And then I've put some other conditions on the right-hand side, and I'm going to talk about those as well. Thrombophilias, which are blood clotting tendencies, infections, and basically any medical condition that's not well controlled. So if you have a known medical condition like kidney disease or liver disease, if they're not well controlled, just being generally unwell or not in optimal health can have a negative effect on an embryo implanting. So I thought first I'd talk about diabetes. With diabetes, there's type 1 diabetes and type 2 diabetes. Type 1 diabetes is often diagnosed in childhood, and that's usually insulin dependent, and that's usually considered an autoimmune condition. Type 2 diabetes is often adult onset and can be associated with increased weight gain, and it's usually responds to tablets rather than insulin, although sometimes if it's very poorly controlled, it also requires insulin. We know whether it's type 1 or type 2 diabetes, we know that having optimal glucose control is really important to make a great environment for the embryo to implant. For those patients who have an endocrinologist already who's managing their diabetes, it's really important to see them, be reviewed, and make sure that they're in the optimal medical position to have an embryo implanted. For people with type 2 diabetes, if they are overweight or they do have a poor diet, then addressing those factors can help improve the glucose control. And sometimes if they've been trying to manage with diet but it hasn't been working, we may think about adding in some additional medications like metformin, which can again help improve the general glucose control and environment in the uterus. Women who do have diabetes should be taking a higher dose of folic acid when they come through and have treatment, and that's also really important for the developing embryo as well. It's also important to check what other medications you're on. There are certain medications, for example, steroids, that if taken can actually make diabetes worse. So it's good to sit down, whether it's with your endocrinologist or your fertility specialist, to see, what things you can do to try and optimize the diabetes control. Thyroid disease is also really common in our patient group, being young women who are trying to get pregnant. Thyroid disease, whether it's overactive or underactive, can affect the chance of an embryo implanting. Sometimes thyroid disease is also related to autoimmune conditions, and sometimes when you test someone's blood, you will see they have antibodies that can specifically attack the thyroid gland. So often with overactive thyroid, some women might have a condition called Graves' disease. Sometimes when it's an underactive thyroid, it might be a condition called Hashimoto's disease. Sometimes women can just have thyroid antibodies, but their thyroid function is actually normal. And these particular antibodies, called thyroid peroxidase antibodies, there are a couple of studies saying that they might be implicated in women who have reduced implantation and increased miscarriage. So sometimes providing your thyroid hormone isn't already high, it might be an option to give a low dose of thyroid hormone if you have these antibodies present. It is important to know that when you are pregnant or when you're trying to get pregnant, it's important to have a much tighter control of your thyroid function than what you might normally have. So often the thyroid stimulating hormone, the range is somewhere between 0.5 and 5. But for women trying to get pregnant, we really want that TSH level to ideally be under 3.5. Thrombophilias. Basically, this is a very long word to say blood clotting tendencies. There are quite a lot of them. I've listed some of the more common ones that we can test for: factor V laden, prothrombin gene mutation, protein C, protein S, antithrombin. So these are little factors that are in your blood which might make your blood a little bit more likely to clot. Most people who have a serious blood clotting tendency probably already know about it, but some people might be carriers for a milder form of a blood clotting tendency. When an embryo goes to implant, it has to send tiny little blood vessels to join with the woman's blood supply. And when it's sending out these blood vessels, which are like little roots of a seed, these blood vessels are very tiny compared to the mother's blood vessels. And if the mother's blood is a little bit thicker, it might make it harder for those tiny little blood vessels to establish a proper sort of connection to the maternal blood supply and start to thrive and develop and grow. And so if you do have a thrombophilia, it might, if your blood is thicker than normal, it might be stopping the embryo from making that initial attachment. There are blood tests that we can do to check for these things. As I said, most people who have a thrombophilia probably already know about it. They've maybe had a blood clot in the past, but occasionally we can find some undiagnosed conditions with testing. Infection. So a lot of the time women will have symptoms of infection, be it a discharge or an odour or a fever or pain, but sometimes you can have an infection in the genital tract and you might not have any symptoms at all. But if you do have an infection, then it can stop an embryo from implanting. Some of these infections might be detected on a swab. Some of these infections, like chlamydia, gonorrhea, mycoplasma, can actually be tested on a urine sample. The fourth option I have there is endometritis. That's when there's actually infection in the lining of the uterus. That won't always be picked up on a swab or a urine test, and sometimes you do have to do a more invasive test where you actually get a sample of the lining of the uterus and then send it off for formal pathology testing. And sometimes we can see that someone has quite significant inflammation of the lining of their uterus and they actually have no symptoms at all. And so with infection, it's really important to check for those things because they're easy to diagnose and they're very easy to treat. So now I'm going to talk about various anatomical and gynecological conditions that can also affect an embryo implanting. Polyps, fibroids, funny shaped uteruses, scar tissue, the lining of the uterus, tubes, endometriosis, adenomyosis. There's a lot of topics there, and I'm going to try not to get too bogged down in things. So on this slide here, I have a picture of polyps on the left and fibroids on the right. So polyp is like a fleshy skin tag. I'm sure some of you might have had a skin tag removed at some time. And a polyp can grow inside the uterus. Around the polyp, there is some inflammation, and it sort of makes a whole no-go zone inside the uterus where the embryo doesn't want to implant because the polyp is there and it's creating inflammation. The bigger the polyp, the more of a negative effect that it will have on implantation. Generally, we would say a polyp probably needs to be at least 1 centimetre in size to have a negative impact. To remove a polyp, you have to have a little operation called a hysteroscopy and polypectomy. So we do that through the vagina, done under a general anaesthetic, and we go in, have a look with the camera, see where the polyp is, grab it, pull it out, and then we're done. So it's quite a quick procedure, but it is usually done in an operating theatre under anaesthetic. On the other side of the screen, I have fibroids, and this is showing several different types of fibroids. So fibroids are, we call them tumours, but they're not usually cancerous. They're made of smooth muscle tissue, and about 30% of women will have a fibroid when you do an ultrasound on them. Most fibroids do not cause an issue with conceiving or implantation, but if a fibroid is especially big, or if it's in a location that would, again, impact on the embryo implanting, then that might cause an issue. So if you have a look at the little slide I have, you'll see there's one fibroid that's called submucosal, and you can see that that one's actually pushing the lining in, and what we say is distorting the cavity of the uterus. And so a little bit like a polyp, around the fibroid is an area of inflammation, and it makes it hard for the embryo to implant there. In this picture, you'll see there's quite a large fibroid right at the top of the uterus. That's the one labelled fundal subserosal. And even though that fibroid is not pushing in on the uterus, it might disturb the blood flow through the muscle of the uterus and still affect implantation from that position. With fibroids, some fibroids are able to be removed through the vagina, a little bit like a polyp, but unfortunately some of the big fibroids do need to have an abdominal procedure to remove those. Sometimes it can be done via keyhole surgery, and sometimes it does require open surgery as well, depending how big it is. So Malarian abnormalities. This basically means women who are born with unusual shaped uteruses. So the picture on the left is what the normal shaped uterus should look like. So some women, their uterus, well, in all women, our uteruses develop in two halves that come together and join. And usually abnormalities can happen when one half doesn't develop, and that's called a unicornuate uterus, or if the two halves don't join properly. And that can be like a bicornuate uterus or a septate uterus, or sometimes this more extreme uterine didelphys. Unfortunately, the shape of the uterus cannot always be changed. That is how you're born. If you have a septate uterus or a subseptate uterus, that can be resected, but the other abnormal shaped uterus can not actually be changed. Sometimes when I have patients with these conditions, not with a unicornuate uterus, but people who have bicornuate or uterine didelphys, there might be one side, one half of the uterus that's a little bit bigger, or the lining's a bit thicker. And when we go to implant an embryo, we will sometimes try and aim to place the embryo on the side that's looks to be a bit more receptive to an embryo going back. So in my next slide, I'm talking about the lining inside the uterus, and I've written here adhesions. Adhesions is a medical word meaning scar tissue in the uterus. I've got thin lining and Asherman Syndrome. So adhesions, there's some pictures on the right here showing some scar tissue inside the uterus. Often this happens if there's been an infection or potentially multiple medical procedures, like you've had a baby and maybe you've needed to have a curette performed after the baby was born because there's a bit of placenta stuck behind, or you've had a miscarriage and there's some tissue left behind and it's become infected. So these are the more common reasons why people would have scar tissue. So when there are these bands of scar tissue, they are fibrous, they don't have a good blood supply, and it's very hard for the embryo to attach to that scar tissue. It also changes the shape of the uterus and it makes it hard for pregnancy to grow. So even if an embryo implants, there might still be an increased chance of miscarriage with these adhesions. So usually we want to go in and try and make the inside of the uterus as normal as possible and try and get rid of all those bits of scar tissue. For some people, in the picture on the right, you can see there are actual bands of scar tissue. But for some people, there's so much scarring that the lining of their uterus is actually very thin. And even when you remove the scar tissue, the lining is still quite thin and doesn't thicken up. And that's quite a difficult situation to try and fix. And sometimes that requires hormone treatment, maybe some blood thinners. There are quite a few different strategies, but there are some people, unfortunately, where the damage and scarring to their lining is so significant that it's not possible to fix that problem. Asherman Syndrome is a sort of a name encompassing adhesions and a thin lining. So it's not necessarily anything different. It's just a general term to imply that there's scarring and a thin lining in the uterus. So next slide is about hydrosalpinx. So if you have a look at the picture on the left, you'll see a uterus, and on the right side there's a normal tube, and on the left side there's a very inflamed, swollen tube. So that tube is usually blocked and filled with fluid. When we do IVF, we don't use your fallopian tubes. So you might be thinking, well, why would I be worried about an inflamed tube when I'm doing IVF and I'm not using that tube anyway? The fluid that is inside the tube can actually be bit toxic to embryos. And so even if we don't use that tube at all and we do IVF and we put the embryo back in, the fluid from that tube can leak backwards from the tube into the uterus and have a negative effect on the embryo implanting. And actually, it's quite a significant negative effect. Unfortunately, once a tube has been damaged enough to become a hydrosalpinx, it's doing surgery to try and repair that is not usually effective. And usually we would actually just want to remove the tube. And obviously, if you remove a tube, you can't get your tube back, but you will actually improve your fertility significantly by getting rid of that tube. The picture on the right is an X-ray called a hysterosalpingogram, and that's where they inject some contrast that shows up on an X-ray. And you can see on the right side, the contrast has gone into the tube and it's formed this big hydrosalpinx. And on the left side, the tube is blocked. You can't see any fluid going through. So now I'm going to talk to you about endometriosis and adenomyosis. They are really big topics, and Samir already alluded to the fact that they, in particular, endometriosis can affect egg quality. I think some of my colleagues have already given a webinar on endometriosis, and so it might be worthwhile at some stage going back and having a look at that if you are affected by endometriosis. So endometriosis means that cells that are similar to the lining of the uterus, the endometrium, are growing outside of the uterus. And you can see in the picture on the left that there are cells that are growing on the tubes, on the ovaries, and on the outside of the uterus. These cells, these endometriosis cells, release various inflammatory chemicals and compounds. They can affect egg quality. They can affect the sperm, like when you're having sex naturally and trying to conceive naturally, it can affect the sperm when it enters the uterus. And one thing we know that they can do is affect the chance of the embryo implanting. So if you do have endometriosis, it's good to have your uterus in the best possible, or your pelvis in the best possible condition prior to having a transfer. That might involve a surgery, a laparoscopy surgery, to go and remove all the visible endometriosis. Sometimes if someone's had multiple surgeries, we might try a medication. The group of medications is called Gnrh Agonists, and it might include Zoladex or Synarel. And taking a course of that medication for a few months might help sort of shrink and suppress any endometriosis that's left behind after surgery or can't be excised. Adenomyosis is a little bit like endometriosis in that the cells are the lining of the uterus, the endometrial cells, but they are growing within the wall of the uterus, as you can see in this picture on the right. And often they make the uterus a bit big and bulky, and sometimes they can cause very heavy and painful periods. With adenomyosis, unfortunately, you can't really cut this out very easily. If you had a look at that picture on the right, if you tried to cut all those little bits of adenomyosis out, you're not going to have a uterus left. So if someone does have adenomyosis, potentially, again, we may try a 3-month course of one of these medications like Zoladex or Synarel to try and suppress the adenomyosis before having an embryo transfer. Now, a lot of women have adenomyosis, and not all women are needing to do this 3-month suppression. There are lots of women with endometriosis and adenomyosis who do conceive without needing these things, but it's something to consider if you are having recurrent implantation failure. So we are now at questions, and I think we have already had quite a few questions coming in even before the webinar. And I think Samir's bringing me a couple of questions already. He's probably given me the hard ones if I know Samir. So Samir, the first question says, should you keep rechecking your thyroid antibodies and only transfer when they are in the normal range? I don't routinely check people's antibodies. I'm really monitoring the thyroid function, which is mainly thyroid stimulating hormone, TSH, and thyroid hormone, which is T4. If I have someone who's got normal thyroid function and they have thyroid peroxidase antibodies, I might give them a low dose of thyroid hormone for the antibodies, and then I might recheck their hormones just to make sure that I'm not giving them too much, but I don't recheck the antibodies per se. With other conditions like Graves' disease, I do know that endocrinologists do sometimes monitor the antibodies in those conditions, but that's a more unusual thing. Most people have the antibodies that we see with Hashimoto's disease, which is thyroid peroxidase and thyroglobulin antibodies. Next question, does diabetes in the male partner affect IVF success? And the answer is yes, it equally has an effect on men and sperm quality as well, not to mention ability to ejaculate and just the normal semen parameters. So again, just trying to get that optimal control. If you're type 1 diabetic, looking at your insulin regime. If you are type 2 diabetic, trying to look at more the lifestyle issues like losing weight and diet and exercise. So the next question says, the slide said steroids should be avoided if you have type 2 diabetes, but what if you need it for high T cells or other immune issues? So what I would say, I assume this question is referring to natural killer cells, and I knew someone was going to ask, so I'm going to have to answer that. So natural killer cells are immune cells that are produced in every single human. We have them in our blood, and women also have a special type of natural killer cells that are only found in the uterus. In actual fact, natural killer cells are actually an important part of the immune response to pregnancy, and do actually have a role to play in implantation. So we don't expect you to have no natural killer cells. Everybody will have natural killer cells. I think at the moment, our evidence about how natural killer cells interact with implantation and miscarriage, it's still an evolving area. I think the main issue is we don't actually have a reliable test to actually assess what someone's natural killer cells are like. If you do a test on a woman every day, her natural killer cell levels will vary. So they can be high on one day and then they can be lower the next. And depending when you actually get the sample and test will influence your decision. So it's not to say that taking some steroids may not be an option for treatment if you have an immune condition, but I think it's something that you have to discuss with your doctor, and you have to weigh the pros and cons of taking prednisolone or a steroid, and make sure you have eliminated other more obvious and I guess proven causes of recurrent implantation failure first. With regards to the diabetes, we do know that steroids do make diabetes control worse. So if you and your clinician decide that taking steroids is the right thing for you to do, then you are conversely going to really have to work harder on making sure you've got optimal control of your diabetes, because you may actually be undoing like the benefit of taking steroids may be completely undone if your sugar control is completely out of whack because of steroids. So it's definitely something that you need to talk about with your doctor and weigh up what's the right approach to you. Can a cold negatively impact a transfer or implantation? Look, normally we all get colds all the time. If you're like me, you haven't had a cold for about 18 months since you've been wearing masks and washing hands. But look, people get colds all the time. Lots of women get colds and they're pregnant and they don't have a miscarriage and there are no issues at all. I think the main issue is if you have a fever. So we know that having a high temperature for a sustained period of time can have a negative effect on an embryo implanting and can also contribute to miscarriage. So if you do have a cold, if you've just sort of got a sore throat, runny nose, I wouldn't stress too much about it. If you're having a high fever, I would be taking some Panadol, using a cold face washer, and maybe even seeing your GP for some antibiotics or an assessment. If you're actually having repeat fevers, you may actually have something more serious than a cold. Can I get the Pfizer vaccine while on IVF medications and or while pregnant? Absolutely yes, and we encourage everybody who's eligible to be vaccinated. Sometimes when you have a vaccine, you can get a febrile illness, especially in the couple of days afterwards. So from that perspective, we are saying to our patients, maybe if you know you're going to be coming in for an egg collection around a certain time or an embryo transfer around a certain time, don't get vaccinated right before then, because if you come in and you've got a fever, the hospital is probably going to send you home and say, we don't want you to come in case you need to have a COVID swab before you can have your procedure. So I guess I would say try and work out a good time to get it done when it's not going to impact on you actually having procedures. But other than that, we are completely encouraging everyone to be vaccinated. Is there anything else that can be done besides testing for natural killer cells and an endo scratch that can help with the implantation process? So that's a really big question. So with one thing we do routinely at New Life IVF is we do use embryo glue. So this is a sticky substance that we put in the catheter when we transfer embryos, and there is good evidence that there's a small but real increase in implantation rate when we use the glue. So we are using the glue on everyone routinely. We don't actually talk to patients anymore about doing that because we just add it to the transfer per catheter when we put your embryos in. There are, so we've briefly spoke about the natural killer cells, and as I said, it is quite controversial. There are some other controversial causes of implantation failure, and I think if you do a deep dive on the internet, you will find all sorts of weird and wonderful things. And I would encourage you, if you think that you have one of these conditions, that you speak to your doctor about what tests are involved, what the treatments involved, what the actual evidence for those tests and treatments are. One additional test I haven't spoken about in my main presentation is endometrial receptivity testing. And what this sort of testing is, it's based on the theory that maybe when we're putting the embryo back, maybe your uterus or your lining isn't quite ready for the embryo to be going back yet. And maybe your embryo needed to go back a day earlier, or maybe your embryo needed to go back a day later. There is tests you can do to assess for this. It's quite expensive. It is based on actually a lot of really good research, but even though a lot of research was done, the actual studies which have looked at the test to see does it really make a difference, they don't really show that it makes a lot of difference to pregnancy outcomes. But it is a test you could consider, especially if you have exhausted every other test and you still don't have an answer. But as I said, you do have to weigh up the cost of the test and the fact that a majority of people will get a normal result and it doesn't really change their treatment. Can acupuncture improve transfer success? And if so, what days leading up to transfer is best? Acupuncture has been really thoroughly studied in IVF treatment. Some studies do show a benefit. Some studies show no benefit at all. But importantly, all the studies show that it's quite safe and the results are at least equal to not having acupuncture. So I would say with regards to acupuncture, it can be helpful for some people with stress management, relaxation, and if you are someone who finds acupuncture relaxing, maybe that's something you could do to help you get through the stress of the IVF cycle and coping through the 2-week wait until your pregnancy test. In terms of what days are best to have the acupuncture, unfortunately, I don't think there's any particular science, but I would say if you have a trusted acupuncture doctor, then you should go and see them and do what they tell you they think is helpful. And often doing it around the time of transfer is recommended. For how long is it just a numbers game? And if you try enough times, will it eventually work? It can, but obviously it can just be a case of trying enough times. And one of my old colleagues had a few stories of people who did many, many cycles of IVF and finally conceived on their 20th cycle of IVF. I think, though, the reality is that your best chance of conceiving with IVF is in the first 3 cycles. It doesn't mean or the first 3 transfers. It doesn't mean you can't conceive in the 4th transfer or the 5th transfer, but then the pregnancy rate with each successive failed transfer gets less and less. And so after, say, 3 failed transfers, it's definitely worthwhile speaking to your specialist about whether you need to do investigations for some of these other conditions. Sometimes the reality is we have some patients who we are putting back beautiful embryos, the lining of the uterus looks good, they've done every test we can think of, and they still don't get pregnant. And unfortunately, that is a really small number of people, but we also don't have the answers for every single patient. How does diabetes type 2 and high blood pressure affect implantation? I think it's more related to the poor control, the high glucose environment, the swings in glucose from low to high, and the elevated insulin levels. It's one of those things that glucose is basically the energy that all the cells in our bodies use to grow and develop. And so if you have disordered control of your glucose right from the beginning, your embryo is not getting the right energy that it needs to keep growing, and also the lining of the uterus and the cells that are there are also not getting the right energy signals to keep growing and developing as normal. So even once you are pregnant, we know that unfortunately in women who do have diabetes, there is an increased chance of miscarriage, and that's with type 2 diabetes and also type 1 diabetes. So that control is really important right from implantation throughout the whole pregnancy. So I feel like I've answered a lot of questions there, and I'm going to hand over to Samir, and he's going to hopefully answer a few more questions for you.
Thanks, Nicole. We certainly do have a lot of questions. I think this is the most questions I've had in one of the webinars we've done. So we'll try and whiz through them. We may not get to all of them, but yes, there's a few themes coming through. So the first one is, could you please provide some information on the percentage success rates for embryo transfer for people above the age of 40? There's a really fantastic resource that I'm directing all my patients to, which is the Your IVF Success website. It's literally yourivfsuccess.com.au, and it is in fact a website launched by the federal government recently to give people realistic ideas about their chances from IVF, just in the knowledge that sometimes the presentation of data might look a little bit more optimistic than it really is. That data is actually every clinic has to report their data to our regulator and to the collector of data, which is ANZARD. And so you can actually put your specific parameters in, your age, the female age, the male partner's age, and the cause of fertility, and get a fairly accurate idea of the chances for you specifically. So there's a couple of questions that are similar. Is it best to take a month's break after having a failed transfer? Or is it okay to keep trying month after month? The good thing is that if you've had a period, the lining has been refreshed, so there's no reason to have a major delay to having your further treatment. I generally say that certainly for FET cycles, for frozen embryo transfer cycles, back-to-back is actually beneficial. Interestingly, Martin, myself and some colleagues looked at the data previously and actually published that there was some evidence that actually having your embryo transfer closer to the time of your cycle was potentially beneficial. So there was certainly no evidence that it was helpful to delay. The next question is, for each embryo transfer, does the success rate increase or decrease, or is each transfer not connected? Essentially, the chromosomes and the complement of an embryo are independent. So if you have an abnormal this time, it doesn't necessarily mean that the next one will be abnormal. But there also does get to a point where if you've had lots and lots of treatment and things haven't worked, that may be indicative of a poorer chance of things working thereafter. Now, does recurrent implantation failure apply per protocol, i.e. 3 failed natural cycles? Then does the count start again if starting an HRT? Unfortunately, it is the total number of cycles. I've just got a little tickle in my throat, so Nicole's going to take over the next couple of questions while I get a glass of water, and I'll be back.
He must have seen a difficult question and decided to leave it to me. Okay, so it says, well, this question is very easy. It says, what tests would you recommend if you have recurrent implantation failure? And I think Samir and I have discussed this, but just to go through again, you might consider doing pre-implantation genetic testing, so chromosome testing of your embryos. As individuals, if you haven't had tests already, you might want to get your own chromosomes checked. About 1 in 1,000 people are born with a slightly muddled up chromosome pattern called a translocation, and that can mean that they're more predisposed to producing abnormal eggs or sperm than another person. And then obviously there are all those blood tests that I spoke about, looking for blood clotting tendencies, endocrine conditions, antibodies, and then potentially a really detailed ultrasound or what's called a hysteroscopy and laparoscopy to assess the uterus and assess the pelvis to look for things like polyps, fibroids, scar tissue, infection in the lining of the uterus, a hydrosalpinx, endometriosis, adenomyosis. Ultrasound, you can get some really good ultrasounds, but the gold standard is to have the surgery. And then I think if you are still not getting any answers after doing all those tests, you are then starting to get into this zone of tests that we can do that don't have as much evidence to support their value. For example, the endometrial receptivity testing, but it is something you can discuss with your doctor. I think there was a question here, do I have an opinion on natural killer cell testing or ERA testing? And I guess I have spoken about these things already. So look, with the ERA testing, if you are a bit tight on money, I would probably say you can skip that. If you've done all your other tests and paying for the ERA test is not going to break the bank for you, then it's a reasonably harmless test to do. With regards to natural killer cell testing, I have to admit I don't usually do it unless someone really asks me to do it. One of the reasons I don't do it is about 9 out of 10 people come back positive for natural killer cells, and I find it creates a lot of anxiety and stress in my patients that they don't need. As I was saying before, depending what day in the cycle you'll get a different natural killer cell result, even on the same woman in the same cycle. And as I said, it's normal to actually have some natural killer cells there. What I normally say to people is I don't necessarily think that having elevated natural killer cells isn't a cause of not getting pregnant. I just don't think we have the right test yet to actually diagnose that. So that's where I stand. Now I'm going to hand back to Samir. He's had his glass of water.
I have indeed. I just saw the difficult questions coming up, so I decided to hand over to you. Now I'm feeling much better. Good. So the next question, we have a similar. I've one for a euploid embryo. What can I do to make sure this transfer works? And similarly, you've had two failed embryo transfers. What should we do next? I think that everything that we've talked about in this webinar is exactly what we recommend. Things like the thrombophilia testing for diabetes, pre-diabetes, autoantibodies, and a good quality scan. I think have a chat with your fertility specialist if there's any merit in doing a physical procedure to have a look, whether that's a hysteroscopy or laparoscopy to exclude polyps, fibroids, and hydrosalpinges. A good scan and maybe even a tubal patency test is a less invasive way of finding that. So it does come back to the investigations that we've discussed today. Does too high progesterone affect receptivity and implantation? It's interesting, some of the I guess most successful and high pregnancy hormone pregnancies I've seen have had progesterone levels in the many hundreds. So personally, I believe there's a threshold effect. You need a certain amount of progesterone for successful receptivity of the lining, but above that amount, there's no such thing as really too much. The next question is, how thick is too thick for lining for endometrium for transfer? Now, every clinic has different protocols. Usually that minimum for a transfer is 6 to 7 millimeters. Interestingly, we spend a lot less time worrying about the maximum. And the only caveat to that is we want to make sure if you do have those really thick linings, and that could be 14 millimeters or above, that you don't have an endometrial polyp. Because if you have a polyp between the two sides of the lining, that can look like a thickened lining. And that's a fairly simple thing to exclude, and it is just a scan in the early part of the menstrual cycle to see if that indeed is still present, which if there is a polyp, it will still be thickened. Next question is, does New Life offer the PRP procedure for recurrent implantation failure? It is possible to have PRP treatment, but it isn't something that is routine. It would really require a detailed discussion with your own fertility specialist, just because there isn't a lot of data out there and it is an expensive process. Can you add aspirin safely to a transfer protocol, or is there a test for needing it? So it's interesting, the indications for having aspirin more for benefit of pregnancy rather than proven implantation benefit are increasing. There's more data that it actually helps with things like blood pressure problems during pregnancy, particularly for those who've had pre-existing problems with their kidneys or blood pressure, or who are older when starting their journey. So I must say I have a very low threshold for aspirin. That said, the specific studies looking at does it improve implantation are mixed, and the jury's out, and it probably has more effect later in pregnancy than on implantation per se. Then the next couple of questions are to do again with NK cell testing. I think Nicole dealt with that very well. It is an evolving area. It's still controversial. Should you try intralipids, LIT, or DQ gene testing? And do you believe in using IVIG and intralipids? It's interesting, studies out of the 1990s showed that if you do have that DQ alpha match, there may be a delay to falling pregnant naturally. And some specialists therefore extrapolate to say, hey, then that means that doing IVF, this is a problem and we ought to try and fix it. The reality is that hasn't been borne out in any clinical IVF studies. So I personally do not recommend DQ alpha testing. LIT and IVIG are treatments that have serious potential side effects. And for instance, IVIG can cost many thousands of dollars per cycle and the risk of severe reaction. So personally, I don't use IVIG. I think with intralipids, again, it's a really detailed discussion with your doctor about the pros and cons of using it, what they're trying to achieve, and what evidence they're basing that recommendation on. I've got a couple more, and then I think we're nearly there. So, does an ectopic pregnancy influence recurrent implantation failure? Is any implantation positive? I really do keep ectopic pregnancy in a separate category to implantation or not, simply because implantation in the tube is very different to implantation in the uterus. So if you've had a positive pregnancy test from an ectopic pregnancy, I wouldn't say that that fits the definition of recurrent implantation failure or not. I think it's a separate category of pregnancy. That said, if you've had an ectopic pregnancy in the past, it's been fully treated, and there's no hydrosalpinx, then that shouldn't have a long-term consequence from your IVF or on your IVF treatment. And I guess very specifically, the risk that I worry about when someone's had an ectopic pregnancy is that risk of damage to the tube that results in that fluid accumulation that Nicole mentioned does have a harmful effect on pregnancy. The final one I've got, and I think that might be the last one for tonight, is does endometriosis surgery increase the chance of implantation success? Again, the studies are mixed. There are some studies that say actually moving forward with IVF and leaving the endometriosis in place, particularly if it doesn't have symptoms, may be the best route to go. Although, that said, people have had lots of failed implantations, and also in the presence of severe endometriosis and symptomatic endometriosis, it's very reasonable to treat that. There are a few studies that say treating that deep infiltrating endometriosis prior to moving forward with further IVF actually has a potential beneficial impact. Again, it's about the pros and cons. So if you're otherwise asymptomatic and fully treating your endometriosis would involve a major operation with things like a bowel resection and the risk of a stoma, we'll balance that against the the merits of simply moving forward and doing other things like making sure we've done your embryo testing, making sure the environment's optimal, making sure we've done that thrombophilia testing and testing for autoimmunity. Good. And last couple of things. We would emphasise that the COVID vaccine is safe to take during the IVF process. The recent guideline change, I think it was just this week or last week, was that all pregnant women are eligible and it is safe to take the COVID vaccine. So fully encourage everyone to have the vaccine so we can finally get out of the situation that we're in. Our next webinar is on the 7th of September on unexplained infertility explained. And the recording of this webinar will be up on our YouTube site in the next couple of days, which is www.youtube.com/c/newlifeivf. I'd like to thank everyone for joining in today. We've had lots of fantastic questions and hope that that's been beneficial. And of course, if you do have any further questions, do direct them to your fertility specialist.